we can go on and get started. Wonderful weather we have, huh? Unbelievable.
Hi.
My name's J.C. McCauley.
I'm Naisha McCauley, and you're watching AccessTV.org.
You know, I lost about, I don't know, a good portion of our audience to this weather. They couldn't be found. So such are things. Good evening, everyone. My name is Mark Jenkins. I'm the Executive Director of the Greater Hartford Harm Reduction Coalition on behalf of Dr. Rule, and who will be joining us in the Hartford Health Department. Hartford Health and Human Services would like to welcome you out to tonight's forum. This is part 4 in a series of forums that we've held discussing issues and events surrounding the opioid epidemic that we face here in the state and the various efforts to combat what's going on, to have some open discussion about it. And we've come from a variety of different angles. First, starting out talking about the CORE initiative, which was developed. The CORE initiative, if you don't know, is the state's response to the opioid epidemic. And we talked about different options, treatment options. We've talked about abstinence-based treatment. We've had representatives from the faith-based community, just really all around the board. And tonight, we're going to kind of close that circle, if you will, as we begin to discuss medication-assisted treatment, okay? Which has probably been heralded as the best practice in combating this. And good to see Mr. Young. How are you, sir? Angela, you know what? I tell you what, why don't we do this? I'm going to invite Angela to come up and have some housekeeping so she doesn't give me 80 messages. Alrighty. So she's informing me, please, your phones, if you don't mind silencing your phones. And the other housekeeping are the bathrooms. The bathrooms are outside those glass doors. Men to your left, and I believe women are where, Angela? To the left also? Okay, just a little farther down. Okay, again, tonight's forum is going to discuss medication-assisted treatment, various forms, and I'm really glad to have some of the people we have present here today. I'm not going to put them on Front Street, but I'm just glad that they're here. And also some people I've known for quite a while, and some were just recently meeting, and they form, and I was also given some other information that we'll share as well. But in the interest of time, because we want to make sure we can get some good conversation in today, I'm going to begin to introduce everyone, and I'll start from left to right, and we're just going to, briefly have them discuss, their programs, where they come from, what's available, and we'll save feedback and questions for the end, if you don't mind. All righty? So first we have Dr. Edith Hergan. She's from Connecticut Addiction Medicine. All righty, Connecticut Addiction Medicine. Dr. Edith Hergan graduated from the Illinois Institute of Technology in Chicago with a Bachelor in Science degree, Cum Laude, In biology, she completed a Master of Science degree in cardiac physiology and an MD degree from the Chicago Medical School and University of Health Sciences, Chicago, Illinois. Dr. Hergan completed her internship at the Michael Reese Hospital and her anesthesiology residency at the University of Illinois, Humana Hospital in Chicago, Illinois. She completed a fellowship in obstetric anesthesia at the University of Illinois, Humana Hospital. And during her years of practice, Dr. Hergan has received numerous academic and clinical honors that include serving as an assistant clinical professor at both the University of Illinois and medical colleges of Wisconsin. She also served as chief and medical director of anesthesia and preoperative medical and pain management at the University of Illinois hospitals and medical colleges of Wisconsin. She is currently a member of the American Society of Addiction Medicine, and Dr. Hergan devotes her full-time practice to all aspects of addiction medicine at Connecticut Addiction Medicine. Dr. Hergan.
I represent the Connecticut Addiction Medicine office. No? Nobody can hear me. I don't think it's on. Is it on?
It's on.
Okay. All right. So I'm with the Connecticut Addiction Medicine offices, one in Rocky Hill and there's one in Hartford. I've been working with them for a little bit over 3 years now. We offer a varied number of services. Our main goal is abstinence-based treatment. It is a medically assisted treatment center that uses both Suboxone and Vivitrol treatment to treat both opioid and alcohol dependence. We have firm belief in bridging the gap between detoxification services and inpatient services and setting up appointments immediately as people finish their services, either inpatient or a brief outpatient treatment. We offer same-day appointments. We have various services, as I've mentioned. We have therapists for biopsychosocial evaluations. We have therapists that run relapse prevention groups, as well as all of our physicians run relapse prevention groups. Patients are seen weekly at first and attend group weekly for the remaining of their treatment. And as time goes on and patients become more stable and are able to complete and are able to have sustained abstinence, their visits are a little less frequent. We have a very high retention rate. We seem to retain about 70% of our patients about a year through treatment. It's personally disheartening to me when we do lose some patients, but this is a chronic disease of relapse, and a lot of our patients, even though they may not be successful at first, do return to treatment. We offer urine toxicology. It is comprehensive and it is state-of-the-art. We offer all our patients addiction education. We have a very close relationship with inpatient treatment centers, IOP, partial hospitalization centers throughout the state of Connecticut. And what else can I say that I haven't already said? We welcome those that need help. We're committed to helping and retaining our patients. And we treat everyone with respect and hope that, and I hope that they feel exactly what we offer. So, thank you. That's it.
Okay, thank you. Next we have Masood Leroy. Okay, Carol is over at Healthcare Resource Centers, formerly known as Community Substance Abuse Centers or Fish Fry. That's how most of us affectionately know it. Okay. She's been the clinical director 5 years at CSAC in Western Massachusetts, Community Substance Abuse Centers in Western Massachusetts, oversaw the clinical departments for 4 different sites. She has a master's degree in counseling psychology from Boston College, a bachelor's degree in psychology from Boston State College, a CARF accreditation surveyor for 15 years, and member of a team that conducts accreditation visits nationally for outpatient treatment programs. Carol.
Okay. Good evening, everyone. I want to first say that it's a pleasure to be here. I've attended, I think this is my 4th, how many forums have been? Okay, so I've tried to attend all of them, and I want to just thank Mark for his tireless efforts. He's a powerhouse. GHHRC is also, what they've done is just incredible. They've brought diverse people together to have dialogues about very important things. So I'm very happy to be here. I'm actually now the practice manager at Healthcare Resources Centers, and we're an outpatient medication-assisted treatment program that's located in Hartford. We currently service 650 patients. We do only provide methadone at this point and hope to, in the near future, be providing Suboxone as well, and outpatient treatment. We have a variety of groups that we offer to people. We try to be as diverse in terms of what we offer people and gear it towards their recovery. You know, what I would like to do is something a little bit different, because I talk all the time and I'm very boring. So what I'd like to do in preparing for this, just say some statistics. We deal with these statistics every day, and I was still shocked to hear some of the numbers. You know, the numbers, I think they say a picture, you know, reflects 1,000 or speaks 1,000 words. I think this does too. So one other thing I'd like to say is that what they're calling the opioid crisis now is a curious sort of thing to me. The crisis did not just begin. It's not a new crisis. I've worked in substance abuse for 30 years. It was a crisis 30 years ago. I think the difference now is the demographics are much different. When it was a problem in the inner cities and it affected people of color, people were not calling it a crisis. It was someone else's problem. Nobody wanted to deal with it. Now it's in people's backyards, people's sons and daughters. The governor of Massachusetts has a son who got addicted to heroin through pain medication. This man cannot do enough. He's got, like, you know. So my point being that it is not something that's new. It's been around for a long time, but just something that's coming to light. So we all who work in the field are delighted and really don't care what brings it attention to the problem. We're happy that you know, people are talking about it. So on to the numbers. 2000, the number of drug overdose deaths in Connecticut between 2012 and 2015. To put my glasses on for this. 357, the number of deaths in 2012, overdose deaths in Connecticut. So that was 2012. 2015, the number went up to 729, and the latest statistics available for 2016, 917. The average age of a fatal overdose victim is 42. The oldest victim in Connecticut in 2016 was a 73-year-old man who passed away from heroin and alcohol use in a Hartford park. The youngest victim was a 17-year-old girl who was found dead in a motel room. in New London from an overdose. 2 people die every day in Connecticut of a drug overdose. So we're not just talking about overdoses, we're talking about deaths due to overdose. Connecticut has just been fortunate enough to get a grant from the federal government of $5.5 million. It's a grant from Health and Human Services, and it is being provided to combat opioid addiction. Number of deaths in Connecticut by town, I'll just read the top 5. Hartford, not surprisingly, has the top number of deaths through overdose, which was 84 in 2016. New Haven comes next at 70, Bridgeport number 3 at 49, Waterbury is number 4 at 36, and New Britain is number 5 at 33. Connecticut, for the 3rd year in a row since 2013, has surpassed the national death rate for drug and opioid overdoses. Deaths involving fentanyl, which you've probably heard about, saw an enormous increase, 155% in 2016, with 479 related deaths. Fentanyl, we hear a lot about it being mixed with opiates. People don't even know that they're buying the mixture. Is very potent, but that was very rare until a few years ago. Fentanyl's 30 to 50 times more potent than heroin and 50 to 100 times more potent than morphine. Carfentanil is, like we didn't have enough problems with fentanyl, now there is carfentanil, which is, by the way, not approved for human consumption. Vets use it, and they use it as an anesthesia for large animals, most notably elephants. But that is we haven't seen it in New England yet, but it seems to be in the middle part of the country. Ohio's having a terrible problem with it. Carfentanil is 100 times more potent than fentanyl. The opiate overdose phenomenon, and I'm just going to say really quickly, it was sort of the Joint Commission on Accreditation, which most of us have either JACO or CARF accreditation, and they come in and do their thing. They thought that hospitals were not asking enough about pain management back around 2000, 2001, and they began talking about pain as the 5th vital sign, along with pulse, blood pressure, oxygen saturation, and temperature. Pain, however, is a symptom, but it's not an objective vital sign. So they took that and they thought, okay, they've got to be on board with JACO. There was this flurry of just extraordinary overprescribing. So the pendulum swung from one extreme. They weren't prescribing people medications to adequately treat their pain, and that was a shame. It's as much a shame as the pendulum has swung to the extreme other direction, and someone says, you hurt your toe? I'll give you like 90 oxycodones. So in fact, most of the people who are getting addicted now are getting addicted through, people's medicine cabinets, all sorts of ways that, are not that unusual, I guess, but, and then they migrate to heroin because either the doctors cut them off or it becomes really extraordinarily expensive to sustain that. So there's a surplus of medication. People are getting addicted. That's pretty much the modern sort of more recent trend. But we still need to do things to treat pain management. It's inhumane and it's cruel to leave people and to think that they somehow are going to get addicted if we treat them. So, there aren't a lot of pain specialists. It's a very difficult area to try to map out, but we should not stop trying. We have the prescription monitoring program. I think that it started in 2003. It's relatively new. Connecticut mandated its use, or said it was a public act that said pharmacists and physicians had to use it. But it's at about 50% of physicians use it, which is really quite striking. You'd think in light of a crisis, every physician would be looking to see, is someone getting prescriptions from other people, how to really coordinate care. They're not using it, so we unfortunately stay in, the midst of our crisis. So, thank you.
Thank you, Carol.
I can't even move that.
It's always nice to hear somebody quoting those numbers besides myself. Next, we have Eliza Castro. Eliza Castro has worked in the behavioral health field for over 20 years. Ms. Castro has worked both in prevention and treatment and is currently a senior clinical supervisor at the Hartford dispensary. She's a licensed clinical social worker, licensed drug and alcohol counselor, supervises Hartford Dispensary's Weston Street Clinic, and is a member of the Hartford Dispensary executive team. Ms. Castro manages a methadone maintenance facility with 900 plus patients. She strives to deliver quality behavioral health care treatment to opioid-addicted individuals in the greater Hartford community. Ms. Castro has presented at the American Association for the Treatment of Opioid Dependence national conferences on integrating evidence-based therapies for co-occurring disorders and cognitive behavioral therapy for PTSD. Eliza Castro.
Thank you. Good evening, everyone. It's nice to see so many familiar faces. Mark Jenkins and I have a special relationship. The Hartford Dispensary has been very fortunate to have him on site at the Weston Street location and some of the other sites to provide Narcan education not only to the patients that we serve, but to family members as well. He came to countless groups throughout the last year and met with a number of family members who had a lot of myths about methadone services, opiate addiction, and where they could help and when they felt they possibly were enabling their family member. And through Mark's work, through dispensaries work, we were able to bridge a gap with family services where family members often don't participate in methadone maintenance, outpatient treatment, and started to become more involved, which was a really wonderful thing to see. There are still many myths about opioid addiction and methadone maintenance and the effectiveness of the medication and potential harm it may have on somebody's body. We hear myths about methadone getting into people's bones, rotting their teeth, people gaining weight. They can never get off the medication once they start. It's substituting one addiction for another. And through our work at the Hartford Dispensary, we currently serve approximately 5,500 patients in Connecticut. There's 9 sites, plus at my location on Weston Street, there's primary care services and dental services available for our patients, as well as psychiatric services, individual and group services. Having full wraparound services on site for our patients has really allowed us to provide affordable, quality services under one roof, where patients feel accepted. Carol mentioned the prescription monitoring program and doctors not using it nearly as often as they should. We also use the prescription monitoring program. And one of the things that we hear routinely is that patients don't tell their doctors they have an addiction, nor do they say that they're on methadone for fear of the way they're going to be treated or that their treatment is going to be discontinued. So one reason that I'm here tonight is that I want to have a discussion with the community, with folks like yourself, to let you know that you're not alone in that area and that it's our job to continue to shed some light on the disease of addiction, to treat it like other illnesses, and to praise you for coming out and supporting family that you have or yourselves, and continuing to work with us to treat this illness. Thank you.
Thank you, Elisa. Alrighty. Next we have Katie Strahowski. Did I pronounce that right? Okay. Katie is a family nurse practitioner at Clean Slate Center's 85 Gillette Street location in Hartford. Prior to Clean Slate, she worked in an array of critical care settings at a level 1 trauma hospital where she witnessed the devastating consequences of addiction on patients and their families. Katie is passionate about fighting back against this deadly disease and helping patients achieve the lives they want and deserve through evidence-based addiction medicine and Clean Slate's commitment to providing compassionate and individualized care. Katie received her BSN from St. Joseph College and her MSN from the University of St. Joseph. Katie.
Good evening, everyone. So this is like one of my first times doing this, so bear with me. But like I said, I am very passionate about this, and as previous speakers have said, about this crisis. So we actually just opened for business today, so very new. We were up in Massachusetts, all of our staff training. We're an outpatient-based treatment center. We do both opioid and alcohol addiction with Suboxone and naltrexone or Vivitrol. We do injections and tablets. One of our good things about our office is we are open for business Monday to Friday, 9 to 5, but on Wednesdays we're open till 8, so we can accommodate for people in their work lives. On Fridays we do close a little early at 2 o'clock. So, when you come in, you'll always be greeted with a smile. That's one thing that I love about my job. I love going there. I love seeing the people that I work with. And I think we all enjoy what we do. And I think that that definitely shines through in how we do what we do. So everybody gets an initial visit where you talk about individualized care. We're huge on that. Everybody deserves individual, treatment. So we titrate our treatment to what you're looking for and where you want to be. So we are here to help you or help your loved one with their recovery. That is one of the huge things that we're based on. So everybody gets, initial blood work. We do regular blood work, like a comprehensive panel with electrolytes and hemoglobin and all that, as well as infectious disease. We do check for that initially, and then we do check every 6 months. So we follow up with that. We do not treat on site, but we have plenty of places that we can refer to, and many PCPs in the area that we'll be in conjunction with. Let's see. One of our main things that our company likes to call us is Warriors for Hope, because this is a crisis, but if we all can, get together and get on the same level and, have, different points of access and, increase our access, we are hopeful that we can battle back and, fight back against this epidemic. I think that's it.
Thank you, Katie. I have to say, I've got a relationship with both Carol and Elisa, and when we first started doing the lock zone, everybody still hadn't really caught up to it. So we were would roll up in the van and open up the doors and curbside and catch our clients coming out. So it was so grateful they didn't have us arrested. Because it was okay, you can't be at the front door, so we went and stood at the bus stop, and we would catch clients at the bus stop. So again, as people began to warm up to having this medication around, other doors began to open, and so it was at the dispensary. But at this time, what I'd like to do, and also I'd like to have a chance also. I don't see one here. I'd like to acknowledge Robin. Hi, Robin. Hang on one sec. Now, we also have some information over at the tables because Bill gave some information prior to this that's something I didn't know about ICRC, and that you all also have medication-assisted treatment, correct? Correct. All right. So, again, and there's also from Clean Slate, we have another member here. I can't remember your name.
Sure. I'm Dave Mazzetto, one of the practitioners there.
And the office manager at Clean Slate. And listen, one thing we're about really is making sure, especially, and I really want to see more members of the community here, because everything that we do is really about making access to information, medication, services, to make sure that they're really available to the community, and that the community has an idea of putting faces to things also, so we can begin to reduce some of these other barriers. Robin Deutsch, who is from Hartford Hospital, and she does a great work there. I can't remember your name. You were on a panel. Weren't you on a panel? You were on the third panel.
Yeah, so community health services. Yeah, so we have a medication-assisted treatment program there as well.
Thank you. And I'm going to throw my phone at Angela. I'd like to acknowledge Peg Weeks, who is here from the Institute for Community Research, and a lovely young lady she just introduced me to that I swear I just forgot. All righty, thank you. I'd like to, open it up to any questions you may have. I can't, now I see you from Hartford Health, from Health and Human Services.
Tim Nguyen with the City of Hartford Health and Human Services Department. Nice to meet you.
All righty. All I know is he's a really smart guy. And look at there, as if it were on cue, before we get to start, I would like to introduce, without further ado, this is Mr. Dr. Gary Rule with the Hartford Health and Human Services. He is the director of Hartford Health and Human Services. Dr. Rule.
Thank you, and good evening. Sorry I'm late. I got caught in traffic and with some meetings, but thanks for being here. I know it's going to be a great event. The Greater Hartford Harm Reduction with Angela and Mark have done a tremendous job. Thanks for coming out and being part of the forum. And with that, thank you so much for helping us with this discussion. Anything else? That's it. Thank you, and thanks for coming.
So in all of the individuals I mentioned have information and resources on the table, so make sure you also get some of those. But I'd like to really open it up right now to any questions that might be.
First, I'd like to thank all the panelists and everybody for coming today and supporting naltrexone and recovery in a whole. My name is Jenny, and I guess my first question would be for Ms. Elijah? I'm sorry about that. Okay. So, I live in Middletown, but I'm very involved in the community of Hartford and New Britain as well as New Britain Dispensary. And I'm just curious if there's any plans in the future moving forward for naltrexone training to be coming over there for their staff as first responders, or being in the building just in case there is an overdose on the premises, or for in the future if there's any plans for that.
For the staff to be trained?
Correct, or for the clients as well. I know that they can come to the forums on Thursdays, but I know that pretty available in Hartford, but New Britain is also on the map as, I'm sorry, I can't see that far, as you had shared for the numbers for overdoses, so from the community of New Britain, yeah.
Mark, did you get to, where did Mark go? Mark, did you get to go out to New Britain to train the staff there as you did with Henderson Johnson? Okay. Go ahead.
We got down to Norwich, but we didn't get a date yet for New Britain.
Okay. All of the supervisors throughout the agency and the majority of the administrative staff have been trained to use Narcan and have CPR certification. There are nurses and doctors on site as well. So the answer to your question is yes. The staff has been trained in that area. There have also been a number of patient trainings that have been provided. I'm not sure if there has been one in the New Britain Clinic, but we have a resource center at the Henderson Johnson Clinic, and we often provide a variety of different trainings on that and other medical services, infectious disease, as well as other for patients. So may be able to access it through Hartford, and I know that New Britain is working on a resource center similar to ours, and I anticipate they'll have that in the near future.
And I'll add also that there were a lot of people came down from New Britain to the trainings in the resource center on Thursdays.
Yep.
So, don't be shy.
My name is Juan, and I work for Hartford Dispensary in Main Street. And I teach groups in Spanish, and I have seen this community that is growing in multicultural with different languages. And I would like to see the services being more sensitive to the language of our patients, because I have seen Korean, Portuguese, Hispanic, English, and I would like to see if somehow the services can put together something and start to produce some material. I know this is too much to ask because it's a lot of things that need to be done, but it would be nice to be able to provide some information to the patient in their languages where they feel more comfortable so they can understand better. Thank you.
Hi, my name is Stephanie. What I say to that? I say that peers, people in recovery, really need to spread the word to other people in recovery. So each language, really there's a peer movement. A lot of agencies are hiring peers, people with lived experience in recovery. So I think the more people that we get in different languages, just being able to spread the word, in their own community as advocates. Are you talking about like providers or just kind of like advocates for people in general? Yeah. That's how we do it, kind of spread the word. I wanted to ask about something, but I forgot. Oh, medical marijuana. There's a lot of medical marijuana going on, and so how do you guys feel about that? I know it's harm reduction. I mean, I believe in harm reduction, but as providers, how do you guys feel?
Medical marijuana is being used in a lot of interesting ways. Medical marijuana is beginning to be used in a lot of interesting ways. What I heard a couple of weeks ago, they're starting to use medical marijuana in skilled nursing facilities with a geriatric population whose bodies physiologically cannot tolerate giving them opioids. So I think that if we think sort of outside of the box and not vilify every treatment, are people going to abuse it? Of course. I mean, you know, but I think that we have to look at where it can be most helpful and how to, pain management is a huge issue. There aren't enough people who are trained. There's not enough access to pain management physicians. So insofar as medical marijuana is prescribed and used responsibly, I think there's a place for it.
And to add to what Carol was saying, if we as providers coordinate care with the docs that are prescribing it, and there's an ongoing coordination of care and it's prescribed for PTSD, medical issues, what have you, and there's an ongoing communication and collaboration, then we've found some of the patients it to be helpful with, where they may have not had good experiences in the past with other methods of treatment. But it is relatively new.
Can I say one other thing that's just sort of a pet peeve? We do an abysmal job at treating co-occurring disorders. The state of psychotropic medication is just a tragedy in this country. Are you telling me to do that? Okay. Sorry, I'm getting over some viral thing. It's really a tragedy. We do not, you know, we tell people if they're depressed and, you know, it's sort of a chicken and the egg. You don't know what came first, what's the symptom. You know, we do a really terrible job with it. We say, okay, get on medication and maybe in 6 weeks you'll feel better. If not, okay, get off the medication. We'll try you on another medication. And I think we don't appreciate what it's like from the inside looking out, this process of just feeling that you're never going to get better. So I think that there's got to be a way that we can have every kind of treatment. I think that we do best by people if we can offer a full array of different kinds of treatment, because as many people and conditions there are, we need to have not a cookie cutter approach, but really a wide variety of interventions that address people's needs. And when I heard that about geriatrics, I thought, that makes a lot of sense. You know, you're not like sort of plowing people's system with medications that just are too much for them. So. Of course.
Yes, I just want to add that, yes, medical marijuana does have a place in treatment of patients. We do treat patients individually, so we do consider case-by-case matters. The American Society of Addiction Medicine does not approve of or part of complete abstinence means no marijuana as well, but it more refers to the smoking of marijuana, and there are parts of the marijuana plant that are beneficial for pain management and other co-occurring disorders. So it is an individual treatment. It may have some role in pain relief, and because I have been involved in pain management for years, I may approve of it for certain patients, but not for widely used for recreational purposes. So it is a case-by-case, individualized type of treatment. Thank you.
That was a very good question.
I'm just wondering if you'll ever see those two being used from the same, you know, being provided from the same providers. Just because, like you said, the different parts of the plant, the different reasons being used, how do we tell? You know, there's so many clients, so how do we tell who's using it for, you know, addiction and who's using it for medical purposes? Sometimes even the medical marijuana, a person is disoriented, right? Or they're high, and so how do they relate to treatment when they're in IOPs, and then there's some abstinence in IOPs, right? And then a person comes in with a medical marijuana card and smells like marijuana, right? And so it's triggering other people that are there for abstinence. you know, so, I love marijuana, to be honest with you. You know, I think it's great. I think it works for medical purposes. You know, I think it works for anxiety, PTSD. But then I look at the other people that, you know, are getting triggered from it, from the accidents.
I'd like to also introduce someone that I've invited, Christina Gagnon. She's with Roadway of Hope, but she is also a parent who's recently, and she's been involved in the fight and also the struggle and to bring more awareness to the epidemic. And I'll let her fill you in.
So I am a mother of a son who's 22 years old who overdosed on April 10th. He was in ICU at New Britain General for 2 weeks. It was day by day for that first week. It was hour by hour for that first week, so I almost lost him. I started with 3 other moms. We now have a group of over 1,000 people of a group called the Roadway of Hope Connecticut. And what we do is we raise money for all sorts of things, scholarships, sober living, getting people to treatment that have to get treatment outside of the state. We have our big rally August 26th at Hubbard Park. I don't know if anyone's seen Generation Found, but Matt Butler is going to be coming and singing at our event. And I wanted to come today because my son has been addicted since an injury in football when he was 16. So he's been to rehabs throughout the country. And to tell you the truth, medical assisted treatment really has a negative connotation. He had a girlfriend who was involved in medical assisted treatment. She was on methadone, but she did overdose because she was using methadone and heroin. So I wanted to learn more about that. My son right now, he was at AdCare in North Kingston, Rhode Island for a couple weeks, and now he's in the AWARE program out of Hamden, which does home base. And I wanted him to do Vivitrol because I heard a lot of different things about Vivitrol, and also the bridge method. But I wanted to learn more about methadone, and I want to thank you, Elisa, to explain a little bit more to that. I want to keep myself open and aware about what's out there, so thank you. I changed my thoughts about methadone. I was like, never methadone, but to listen and to understand that there's different treatments for different people. My son went through, I don't know, maybe 12 rehabs. None of them worked. So maybe there's always hope. And that's pretty much my philosophy is hope. I've been an advocate. I've known Mark a couple of years. I have administered Narcan on 2 strangers, one in Fall River and one in Providence. I carry it in my car. I'm a saleswoman, so that is my territory. So I'm a huge advocate, but I want to thank you all because it kind of opened up my mind. But we do have a Facebook page, and it's called the Roadway of Hope Connecticut. It's for families and people in recovery, so that's what we like to celebrate. So thank you.
And she's being so humble. These ladies roll deep. They roll deep and they show up and they support things, and if they don't agree with it, they do not have a problem letting you know. All right.
Hi, I'm Jenny again. This isn't necessarily a question. I just wanted to share. I'm a survivor 3 times from Narcan, and I've also been clean from opiates 3 years because of methadone. So there is hope. There is hope.
Hi again. My question is really to the whole panel, and it has to do with emergency departments. As we all know, improving access to opioid addiction is a national public health priority. And emergency departments is an important access point for patients looking for help, looking for assistance. And ED already sees some of these patients, but they offer a little help, as to how to reverse the, overdoses, and especially among the repeated, overdoses. So just want to hear your thought about, how do we move forward, with the MAT program initiated in the ER setting so that it become more readily available, next time they have, individual coming in, with this kind of problems.
I think that these forums have been incredibly helpful in bringing people together, understanding, and I'll use Dr. Deutsch as an example, that I saw her speak at the last forum, and we started a correspondence in terms of how does Hartford Hospital transition people if they've got people in the ED or need treatment. How do we sort of coordinate things? What are the criteria? What are the criteria? And I think that those are really important dialogues to have, because they, at least I'll speak for our program, we are not finding that there is a lot of knowledge about what we do, and there are a lot of misconceptions. And, everybody's got to choose what works for them, but they should at least choose their treatment based on correct information.
We in Connecticut Addiction Medicine have also had these conversations to sort of bridge that gap from the emergency department to actual treatment. We have made our facilities, we have provided phone numbers and we have provided brochures, and I think there has to be a willingness on the part of the patient, the person, to actually engage in treatment. If they're provided with phone numbers, someone to call, we're available many days. We're open till 9 o'clock, and as I said, we do same-day service. So if they're able to come on the same day, even if they don't have an appointment, we realize the importance of treating everyone quickly, because one day goes by and things change very quickly. So I'm not sure how else to provide. We've even thought about actually being able to come over to the hospital and see people before they're discharged, but that in itself is a kind of a complicated, it involves a lot of different steps and manpower. So we offer availability call. We have a hotline that we take all phone calls immediately, efficiently, effectively, and set up very quick appointments as quickly as same day. That's all I have to add.
I agree with Edith. We're on the same page. We can do same day appointments. It's hard to start straight from an ER because a person has to be willing. They have to want, treatment. You can't, if you force it, it's not going to work. So we need somebody to make their own appointment. We can't have somebody make it. They have to want to come see us, as well as we want to help. I know for me, my personal practice, when I initially see a patient and, learn their history, learn everything about them, before I let them leave my office, I have a discussion on Narcan and ask if they're willing, if I can prescribe that for them, so they can pick it up from the pharmacy. And I give them a few refills as well, because maybe they don't need it for themselves because they won't be able to administer it to themselves. However, somebody in their household, somebody walking down the street, and I even have a discussion on how to use it with them, because I'm a big firm believer. I'm like playing it forward. If you teach somebody, they can teach somebody else. We can save lives like that.
There's huge room for improvement. The hospitals need to take more responsibility to help with linkages to care, to make patients who are often coming to the hospital as their point of entry into the system because they've recently made the decision that they want to get treatment, so they go to the hospital, which is not the right place for them, but that was their instinct. So once they show up and we say, we're sorry, we're not a detox center, here's a list of phone numbers, good luck. That doesn't work. We know that doesn't work. And we need to do more to have some handoffs, and that's why I've reached out to a lot of the treatment centers in the community, Connecticut Addiction Medicine, and the dispensaries, to have some of those relationships, so that then we put together some discharge instructions so that patients can get a list of not just the harm reduction approaches, the syringe exchange, information about naloxone, and information about where to go. The current model of operation for the ER physicians is that they think detox. They think getting a bed is the solution. And we know that detox in a year, 90% of people are going to relapse. So the current model really should be emphasizing that people get on medications if they're interested in that. The ER physicians mostly are not aware. So trying to change the culture, trying to change the way patients are funneled through the system is important. So I'm working on putting together information and working with the ER providers so that they understand this model. What we've been doing doesn't work, and that we need to change our thinking.
Our building is currently right across the street from St. Francis Hospital, so they can go straight from St. Francis Hospital to us, right across the street. Yeah, right. Gotta get her name out.
Hi, I'm Bill Young from Intercommunity. I had a comment on what Tony asked a minute ago. Earlier this evening, there was alluded to the $5.5 million that Demas is receiving in federal monies. One of the ways that they plan to use that money, and there is a current RFP out on this, actually is in hospital EDs. If you look at the state administrative services website, there is a very specific proposal that is asking the hospital EDs to come forward, actually, as kind of what Robin was saying, but even take it a step further to begin to initiate MAT in the ED, and then to have community partners with whom they have a warm handoff, so that you can have some continuity there. So that's being discussed right now in Hartford, actually. I will say, because I'm part of one of those discussions, it's not so simple. I just want to put that out there. And one of the reasons it's not so simple is because of the federal rules around who can prescribe MAT, who can prescribe Suboxone. And if any of you have ever spent some time in a hospital ED, you know how many physicians are there around the clock. And so coming up with a way to do this and actually not violate federal law is a little complicated. But I just want to put it out there that the effort is actually being made, and the discussion is active here in Hartford about it.
It's hard to change the culture of providers because in the ER they tend to see people at their worst, people that are in the midst of chaos. So it's hard to convince them that this is something that has a lot of potential for change. They don't see people in recovery that do well. So there's a lot of bias, and it takes time to change that. So there's not much interest right now. We need to put more pressure on the ER doctors to take this up.
Do you think that that has to do with just again the marginalization of the population that we're talking about? There are certain, the language, so we call it, and I sort of smile, we call it medication-assisted treatment. It's like, isn't that delicate? You know, I like the term more, but we're trying not to use terms that just, again, continue to marginalize people and shame them. We call them dirty, we call them clean. Those are horrible terms. You know, they're just absolutely atrocious terms. We should be saying something about it, correcting people, and really just understanding that it is a chronic medical condition like many others, and but for the grace of God, you know, we see people all the time whose lives took a turn, and we are only one accident, one bad injury or medical condition away from someone needing to prescribe opiates to us, analgesics to us. So I think that we have to just remind ourselves that people have been shamed for years, and it's about time that we start to really embrace people and really genuinely help be partners in looking for solutions.
How you guys doing? I'm Michael Serrano from CCAR. I'm a recovery coach, and I'll be being placed at Eastern Emergency Departments. I just want to let you guys know that recovery is possible, because I'm living proof. And CCAR is doing a great thing. They're putting these coaches in the emergency departments. We're not doctors, we're not clinicians, we're not sponsors, we're coaches. We're here to hear what you want. Because in the long run, it's your life. And what are you gonna do after you meet everybody that places you with these medications? You're just not gonna be stuck. You have to go out there and live your life. So yeah, it is a transition. So just know that this is gonna get better. It is gonna get better. Thank you.
Hi, I have more a comment about what the doctor just said. For physicians, the thing that really changes behavior is when you mandate it. So for example, in the ER or with their licensure, when you mandated that they actually had to do an hour or two of domestic violence training, and that was linked to their license, that's how you change behavior. So I would suggest that if you're gonna really change the providers who you're interfacing with, one way to do that is at the system level, by actually having providers go through training about what it means to be in a substance abuse treatment, what MAT means, and really expose them to the language, the lexicon that you want them to use. That's one way to do it. I know physicians will resist, but that's the way to do it.
Hi, I'm Barbara, and I'm an addict, but I'm in recovery, and I've been 6 years, so recovery is possible. I did recovery coaching, recovery support specialist, and like I'm trying to go. I mean, I started out at CCAR, and when they were saying about the ER, CCAR is trying to partner with people, sending coaches to the emergency room for people that overdose. So they need more stuff like that. And some people, like they said, you gotta want it. You gotta want. Can't force this on people. But it ain't easy neither. Cause when I was getting high, nobody could stop me from getting high. It took me till I was 50 years old to get clean. By the way, I'm 57. I know I don't look it. Yeah. But that's it. It's not easy.
I love that shirt too. That's cute. I know.
Hey, my name is John T, and I'm a recovering addict. I've been clean for 8 years. And, you know, I just want to express the fact that, you know, through the process, through this journey, see, you never arrive in this journey. If you think you're going to arrive, then you're probably about to get high again. You know, you never arrive, and the process of recovery has brought a quality of life to me that even people who have never ever picked up had. I have a fellowship that supports me through anything and gives me, even before I go through things, I listen to what other people, their experience, strength, and hope. And it's the therapeutic value of one addict helping another is without parallel. And you know, we're faced with this problem at a magnitude that now all of a sudden everyone in every corner of society is scrambling to find an answer when you've been overlooking the answer the whole time. It's that person who has found the solution by learning that they never have to use again. And you know, getting clean and staying clean are two different things. So you guys meet a lot of people who are trying to get clean. It's the hardest thing in the whole process. And it's not even really recovery, it's just trying to get clean. And then there's a choice. And everyone who says you have to want it is right, you know. At the point of that choice, if that person has the proper supports and proper advice, and they step out on it, there's a world full of, it's beyond your wildest dreams. You know, by using, I thought I had the solutions to all of the problems that I had. But even after I got clean, I thought immediately that I needed to have the solutions. And I learned that it was everyone else around me that had the solutions. And when I stepped into those miracles of my life, it was beyond anything that I could ever comprehend or even come up with. So I just want you to take a look at the whole process of recovery and just know your lane in that process and get that down pat and open your minds up to new information that addicts themselves may have. So addicts are not doctors or anything else, but they are experts. Those who stay clean know what I'm talking about. They are experts in how to stay clean just for the day. So early on in my recovery process, I was introduced to Dr. Bob Painter, who was creating a addiction commission for the city of Hartford. And I would suggest to Dr. Rule, if you can find somebody in the city who can lead this effort again, to convene, and it wasn't all addicts, it was a mix of people who, through volunteerism, could come together and just create standards and build, just collect information on this thing from all quarters of our city. I think that we would have we actually could create a body that could interact with you guys at a higher level. So I just wanted to share my experience, strength, and hope, and thank you.
I just want to say real quick that the Alcohol and Drug Policy Council was reconvened, and there are like 4 different subcommittees that meet. So there are seats available at the table, and I agree, it's one of the only forums that meet about this that does not have a really good representation of the people it's deemed to provide answers to. So it's something that, we can talk more about. I'm not going to take up time with it.
I'd like to thank everybody for sharing. And my name is Michael Reese. What I do is I'm a recovering addict myself. But what I do every day, 5 days a week, sometimes 6, it depends on where I'm at. And if I'm outside and Mark's out there, I'm with Mark. I work for a program called ACT. It used to be AIDS Project Hartford. I sit on a van on Park Street. I'm parked in Hungerford, and what I do is I sit in the back, and I serve the addicts every day. I give them clean needles, I give them condoms, we do HIV testing, we do Narcan, we make phone calls for rehab treatments, and I see this every day, and I hear different stories, because in order for you to exchange, you have to come to that back door. We will communicate. I do communicate with almost every addict that comes through there. I talk to them, I laugh with them, or I don't speak to them at all. But I hear the stories, You remember, what's her name that used to come over here with me? She OD. I hear the story day in and day out. Somebody's dying of opium, off of this drug, and the Narcan's not there. We pass out Narcan from 7 o'clock in the morning to 3 o'clock in the afternoon. And if you come to that van, and you come to that window, after you tell us the needles you want to exchange, and after you exchange your needles, we offer you Narcan kits. We passed out Narcan kits all day today. I don't know if we did 14 or 15, maybe more. And we work off Albany Avenue, right across from CHS on the sidewalk. So if you're ever in the area, come by, visit the van. It's the van parked right across from CHS on Albany Avenue, and I'm on Park in Hungerford, right next to the shelter. We sit there, and what we do is we try to make sure everybody that comes that needs a kit gets a kit. Even if they're coming to get the kits and they're abusing the kits are there because they're no good sitting in the van. And the person that gets the kit is being taught how to use the kit, and at the same time telling that person, please bring somebody else because you can't save yourself with this kit. But the kits are being out there, they're being put out there. And the reason why we have to continue putting them out there because You know, I'm not out there at 4 o'clock in the morning in an abandoned building with that addict, but there's another addict out there with that addict that can save that addict's life. And we had a lot of turnovers since then. You know, I wish a few of my coworkers were here to explain a little bit more. But every day, 5 days a week, sometimes 6, because I work in a homeless shelter, so I see a lot of guys too. And what we do is we save lives. And the way to save lives is to get the word out. Get the Narcan kits out of the van, out of the building, into the hands of the addicts or the people that's gonna use them to save lives. And it's working, but we have a lot of work ahead of us. We have a lot of work ahead of us. Thank you.
Hi, my name is Joel Frazier. I work in Hartford. I have a number of family members in Hartford. And on kind of the policy side of things, Connecticut currently has certain degrees of Good Samaritan laws where if you call 911 and you call the police because your friend is overdosing or you are overdosing, you can do so without being punished with the law. Recently, Manchester, about like 20 minutes east of here, they started a program with their police department where the police are the kind of new face of recovery, where you can go to a police officer and be like, here's my drugs, here's my needles, I need help, and you don't have to be overdosing to get that help that you need. And they become a intermediary for recovery services, things like that. They started this about a year ago. In that time, they've saved 12 to 15 individuals, which, I mean, realistically, if you're saving one person a month from addiction, that's a lot. And something with that too is that's something that really helps with the relationship between the police and the community. A lot of communities that are involved in heavy drug trafficking, heavy drug use, have very bad relationships with the police. A lot of people are afraid of the police. And I honestly think that if I was using drugs and the police were like, hey, you can bring your drugs here and like, we'll help you get clean, like I wouldn't believe it at first. But it's definitely a notion and action that's being taken elsewhere, and success has been seen with it. And I think that if that type of thing was enacted here in Hartford, it could help mend relationships between the police and communities, as well as create less fear around addiction recovery, because that's a big thing too. Like, if you have drugs, if you're around drugs a lot, you're afraid of getting arrested, never mind dying. I mean, you're probably enjoying yourself to a certain degree, but there's the fear of arrest, and like eliminating the fears that come with recovery, I think is a big part of that. So just kind of throwing that out there.
So tonight in our conversation, it sounds like we heard some from advocates for peer support. And it seems like there's a bit of a stigma around the MAT protocol, which to my understanding does require some sort of therapy in conjunction with just medication. So I heard a lot about your individual programs as far as access to medication. But my question is, what types of community supports do you recommend? What types of other therapies, didactic, experiential, things of that nature, do your practices promote? And is there any collaboration between local peer supports, agencies like CCAR, or any other sort of resources that you recommend to your patient population?
I'll speak. We use motivational enhancement therapy with all of our patients. We work with CCAR. We have recovery coaches on site, as well as case managers. So there's opportunities for employment, housing, as well as medical service, as I mentioned before. One thing I didn't mention that is is really unique is that we have an infectious disease doctor treating patients on site for hepatitis C. And as far as other collaboration with community providers, we are very well connected with all of them in the greater Hartford community. We admit patients 5 days a week at the Western Street Clinic, and our goal is to admit people as quickly as possible. Assessing the need of the person is of primary importance, and making sure that you're not missing the opportunity to connect them with the services they need. A lot of them we can provide on site. Those we cannot, we need to make sure that we have connections with providers that can offer them those services. And I think we do a really good job at that. There's always opportunities to work more and add to that. We work with ICRC very closely. We work with First Choice Health Centers very closely. Carol's program is down the street. We exchange a lot of patients from time to time, and that ongoing communication is key.
I would just like to say that I agree, and I think Eliza's program does a fantastic job with the wraparound services, which are important. The other thing, we try to educate people. People are fairly battered when they come into treatment, and we try to just encourage their self-respect. Again, that your worth, we try to give people sort of a political bent on things. If you go to the hospital, if you go to, your son or daughter's school, you have to be able to transact in a world that is very different than what you are used to doing, and to give people the confidence to do that. And I think that's a really important thing. We look at their support network. People, oftentimes family members, have very unrealistic ideas. They come into treatment and then, okay, you've been there a week. Why aren't you better? And why doesn't this stop? And I think the idea that this is a chronic condition, people have a very hard time tolerating. And chronic conditions imply that there's relapse, that there's not always a trajectory that goes up and beyond. And I think trying just to educate people and to get acceptance for people doing the best that they can, and that, we have unrealistic expectations. So I think that the social connections are very, very important, but I think it begins on a personal level and on a familial level. You can't just, from a clinical point of view, I think Eliza and I share the probably thought that you can't just take someone out of the system, treat them, and put them back in the same system. You've got to really be providing some treatment to that system and educating people so that they're all on the same page.
And communicate to them that when there is a setback, when there is a relapse, that they haven't failed, that they've been successful by communicating with their counselor, by talking about their triggers, by talking about what went wrong, and keeping the therapeutic alliance going and continuing to offer support. We need to remember to help the patient stay motivated as opposed to being judgmental and punitive. And it's a long process, and the longer a patient is on medication-assisted treatment, the potential for success is greater. So we want to retain the patient. So family support and peer support is key in helping that to continue.
I love that she just said that, because one of our main quotes is, "You never fail if you don't give up." On site, we have a case coordinator that will work individually with patients and their insurance, and as to what, the patient needs, as well as what, insurance will cover, and, cost if it does not cover, and where we could find the money or, get the money for patients that need treatment and what, exactly they're looking for. But it's for us, it's not like we say, here's your medication, be on your way. You know, each of our practitioners, we sit, and you know, we're allowed a certain amount of time. Do we go over? Absolutely, all the time, because some people just need to talk some days. Other days they don't want to talk. So, you know, I myself, you know, I do a lot more therapy than I ever want to share, and I love it. And I never thought I would say that, but, you know, like just the, you know, back and forth, and you learn a lot. And I think because it's not in a strict environment, patients are more likely to open up. So there is definitely a lot of therapy involved.
I want to ask people, either the panelists or people in the room, for advice as a prescriber who's not affiliated with a larger treatment facility that offers groups. In the beginning, when I do a treatment agreement with patients who want medication-assisted treatment, I emphasize to them how important it is that they have behavioral interventions and that they connect with the recovery community. And I'm very clear with them that the medication alone is not going to change their lives. A lot of patients I encounter are very resistant because maybe they went to a meeting once or twice and they had a bad experience and they said, oh, I don't want to hear the war stories and oh, that doesn't benefit me. And I really struggle with trying to convince people, no, you need to keep going. You have to connect. And maybe people in the room have suggestions or advice for how I can really impress that upon people who say, no, I don't want to hear what they had to talk about. The people in those meetings, they don't want to, you know, they're still using and they're hypocrites. And I hear all these terrible things, which I know aren't true, but making the case to that person who's new that there's a whole world of people out there that are very committed and very serious about recovery, and you need to connect with them.
So how I usually put it out, everyone knows diabetes. Diabetes, the world, no matter where you're from, you usually understand the process. And I kind of try and talk to somebody about it as insulin. You know, you have a diabetic patient, you can't just give them insulin and keep eating that chocolate piece of cake. You know, it doesn't work like that. You know, you give a patient insulin, and as well as change your diet, change your lifestyle, you know, include exercise, change other things. You can't just do one thing and expect to be better. It's a combination of things. And usually that when you use, unfortunately, when you use a medical diagnosis as opposed to, and you can relate to that, then the person, oh, okay, you know, I can't just take this medicine, I have to do other things. So that's usually how I try and relate and, you know, kind of start the dialogue.
There's a website and an app. It's intherooms.com. It's a recovery-oriented, web-based recovery support service. I've gotten really good feedback from patients that have had either negative experience attending groups in the past or don't have transportation to get to a group. People in Connecticut have sponsors through the app in California. It's allowed people to have a new perspective on recovery. It's an ongoing support network that you can get without leaving your home, and it's pretty neat.
Smartrecovery.com as well, and included in addition to the ones in the room.
I'm gonna let Bill make a quick announcement also, just following up on what I said earlier.
There was a comment earlier about for the city of Hartford having a commission, and in fact there is one, Commission on Addiction, and one of the authors was the person who was referred to, the designers was Dr. Bob Painter a number of years ago. So it just happens that there's a commission meeting tomorrow, and I have seen at least 4 people in this room tonight who will be at that commission meeting. So watch for that. I wanted to let you know that there is actually active work going on in the city on the commission, and I think tomorrow we're talking about a public health program that's coming. So just so you know, there is work going on.
Hi, I just wanted to address your question about, I'm a person in recovery, question about meetings and how do you help people who are resistant to meetings because they've had bad experiences. I'm a person in recovery, and I've had a lot of different experiences with a lot of different meetings, and a person has to just, for my own personal experiences, that I have to keep trying different meetings and keep trying different people or different people, different experiences. Some meetings are, you know, people have a lot of years of recovery, and they stigmatize people that are in and out, in and out, in and out. Then there's people who are very open, who've had a lot of their own personal experiences. So the resistance is, there's many pathways to recovery, there's many things to support recovery. So meetings may not be the only solution, but it may be part of the solution, and they have to keep trying different places, different areas, different people. And eventually you find that support group that's gonna work for you. So whatever it is, that's gonna work. And you just have to keep trying it out until you find what is gonna work.
Hey, I just wanted to ask Dr. Rule how the Department of Health and Human Services feels about safe injection sites in the city. As you know, on the one hand, a way to keep people from dying of overdose, and on the other hand, as a place to build relationships with opioid users, so that when they are ready to seek treatment, there's a relationship that's already there. They can be referred by professionals to a place to get help.
That's a great question, and I think you read my mind and you read Mark's and Angela's minds. Since last year, we actually were looking at it because the mayor in Ithaca, New York, also suggested doing something like that, and we were aware that in Canada and in Washington State, that was thought about. So what we kind of thought, what we've been really doing is kind of looking at an evidence-based practice like that, actually even in Europe, because we know that exists. And what we're kind of thinking of, as I kind of talked to both Mark and Angela, actually yesterday, was we think it's a great idea, but then we have to think at several different levels: the system level, a policy change, a recommendation, and then how would it be implemented. And frankly speaking, what we kind of came to is what would the staffing model look like, right? So how many sites, what it would cost. So it's on a discussion, and we just haven't gotten as far as we really should be. But yeah, it's come several times. So we haven't really taken a stance on it so far. Yeah, we're kind of doing the analysis and kind of saying it sounds like a great idea, cities are doing it, and then we're just being very realistic. What would it look like? Is it open 24 hours? Do you need to, how do you staff it? How do you pay for the staff? So we're doing the analysis and we'll make a recommendation. Mark knows a lot more than I do, but we were talking about it actually just yesterday.
And I brought it up also to Dr. Rule because I got to tell you, I just about fell out of my chair when the mayor brought it up in a ComStat meeting. You know, really, and you know me, you know a lot of times I'm biting my tongue in the background because I really want to speak my mind, and I can't now because Dr. Rule's here. But really, safe injection facilities would be great. Like he mentioned, Insight, you know, they've had well over 3.5 million visits since they opened in like 2005, you know, and they've yet to have one fatal overdose. And over 3.5 million visits, not one fatal overdose. And treatment is on site, you know. So there's been a lot of talking, and I'm being the moderator, I can't speak on everything, but I'm also a person in recovery, and I just celebrated 20 years clean, you know. And either way, it really comes down to that individual and where the individual is, and that the individual is okay with themselves, and however that might look, you know. And it's our piece to support them in that endeavor. Again, how that may look. If it looks one way to one person, another way to another, so be it, you know. Third tradition in the room says we have to allow people to be where they are. And yes, I agree that the rooms, and I'm an advocate, I speak up, I tell them, we're killing people. We're killing people because we refuse to change with the times. But again, and also why we like to see and talk about services that are available, because even as this epidemic, we become more aware of it and everything, but as Robin will tell you also, how our service is changing. you know, we're still operating in a 9-to-5 paradigm, but yet and still, you know, services are needed on a 24/7 basis, you know? So I thank our speakers. Can we have a round of applause? Right now I want to give Leda the microphone because she has some gifts. Leda?
Hi, my name is Leda Cartagena. I'm an intern at DHRC, and I volunteer for SICA, and I became a recovery coach. So we got some stuff to give away. So we just picked up 4 names randomly. So the first name is
Teresa Granville. Is Teresa still here? Teresa left? Okay. Joanna Serrano. Hey, come here. You're welcome. Emily Jandro. Emily Jandro. All right. They looked around the room to see who was small enough to fit those shirts. You won't see my name get called or whatever. Danielle Green. She just left? All right. You want to take it for her? Okay. Okay, Peg. All righty. And what's this one? Oh. Pick somebody else. Heather? Heather? Uh-oh, Christina. Look at there. Christina Gagnon. Okay, so I would be remiss and probably have to fight Angela if I didn't remind you that every Thursday we do our overdose education and prevention training, which is always free and open to the public, and upon completion of the training, we dispense naloxone. Okay? So please, there's still food and refreshments in the back. I gotta tell you, we just got a fresh product donation of Ezio auto injectors. Those are the talking naloxone kits. I encourage you to come get one. That's a shameless plug. The training starts 7 o'clock every Thursday night. Now, at 1229 Albany Avenue, there are flyers over on the table. Please help yourselves. Once again, ladies and gentlemen, thank you all. I know it's a beautiful day. You'd like to be somewhere else, you know, but thank you for coming and have a nice night, all right?
My name is J. Stan McCauley, and I do business as Light Source Productions. I provide professional services in the area of strategic video communications. First, what we do is we help you craft your message using what I call the rule of the 5 W's: who, what, when, where, and why. We do event documentation, content acquisition, full-scale productions, editing, and of course distribution through our social media television network. And with social media, Video is more important now than it has ever been. Whether you're talking big business, small business, nonprofit, church, or just an individual. Let's say you plan you're planning an event, a wedding, whatever the case may be. But let's say a big event, but no video. And you spent all this time, all these hours to put this event on, and maybe 100, 200 people attend the event. But more important than that is that thousands could attend by watching it on social media. But of course, you don't think about this until after the event is over. You can't afford not to capture it for social media. And despite what people think, I am affordable. Give me a call. Let's plan your next video project and share it with the world on my social media television network. I promise you that you will have the attention of one person, me.